So what we have to say about hepatitis C is pretty much has the same structure of hepatitis B. So we will start talking about how hepatitis C affects the world. So there are almost 71 million people infected chronically with hepatitis C. Among them, almost 1 million infections occur each year, and there are 300,000 people that die every day for hepatitis C due to liver complications that we will talk about, pretty much for liver carcinoma and cirrhosis. Approximately, there are also 80,000 people that die every day, every year for extra liver complications of hepatitis C. And we have to say that worldwide, Russia and Africa have, Western Africa particularly, have the highest prevalence of hepatitis C positivity. In our knowledge, there are 8 genotypes of hepatitis C. This is important, we will see, because we will have changes in the prognosis of some genotypes differently than others. We see that the most hepatitis C virus in the world belong to genotype 1. That is the most frequent in America, Northern and Southern America, in Europe, in some of Africa's northern countries, and in Australia. We have some countries that are affected by genotype 2, but is genotype 3 that I want to talk about, because this genotype that is spread mostly in India and in other Asian countries has a particularly bad prognosis. In fact, it is considered the most difficult to treat, and also it requires longer treatment regimens, and as I have to say that is the one with the fastest rate of complications. So an infection of hepatitis C genotype 3 causes a rapid appearance of liver complications. Hepatitis C belongs to the Flaviviridae family, but we have to say that is an RNA virus. That the fact that matters to us, it is a rapidly changing RNA virus, and we will see that is important because is the fact of these rapid changes that got the possibility to have a vaccination very difficult. So it is very difficult to develop a vaccination for hepatitis C because this virus changes very rapidly. Another characteristic, we have to say that this virus is transmitted same as hepatitis B, so through blood, through sexual transmission and other bodily fluids, and is important to know that mother to child transmission rate is lower than hepatitis B. It occurs almost in 6% of HCV people, positive people, and this percentage increases in mothers that have also HIV and HCV. What we see in HCV infection, and that is that this infection can become 2 different scenarios. The one that we have a spontaneous resolution, so there are a percentage, almost 30%, 40% of people that have an infection that is self-limiting, and there is a higher rate of chronicization. What we know is that opposed to hepatitis B, in adults, the possibility to have a chronic infection is very high. Because if you remember, we said last time that hepatitis B for adults has not high rates of chronic infection. This is important because in adults, HCV will lead to liver fibrosis and also can lead to the development of HCC, so hepatocellular carcinoma. The clinical features of acute and chronic infection will resemble a lot to the one of other hepatitis virus. So in the acute infection, we have asymptomatic people mostly, and someone will present, for example, malaise or abdominal pain. And these symptoms, if present, will appear around 12-15 weeks after the infection, after the exposure, and can last for a lot of time, almost for 3 months. It is important to know that there is also a little percentage of people that has fulminant disease, as we said before, for hepatitis A and hepatitis B. This is, of course, increased in people who have already other liver infections, such as, for example, hepatitis B. In the chronic infection, we have almost the most of people that are asymptomatic totally, and we can have the presence of HCV RNA in the patient's blood for more than 6 months. It can have also the high liver enzymes, as we said last time for hepatitis B, but it is not as common. It's important to know that this virus can induce liver fibrosis, and this will result in hepatitis complication, as we said before. Most of the people who get chronic infection will develop fibrosis, and among them, we will have a high degree of fibrosis, that is cirrhosis, so a fibrosis of the liver with liver failure, and also the possibility to develop cancer. What are the main complications? We said liver cirrhosis and hepatocellular carcinoma. Of course, this cirrhosis will appear after 20 or 30 years of the first infection. So we are talking about people who, when they develop cirrhosis, are very old. And we have the possibility to have hepatocellular carcinoma. This will be mostly developed in young patients. So this is, of course, a progression that occurs very quickly. Of course, we can have also both of the complications together in some unfortunate scenarios. What do we have to do to diagnose HCV? Of course, the screening for HCV is recommended in people where we have a high percentage of prevalence of positivity, in people born from mothers that had HCV, in people with a history of exposure, so we can talk about risky sexual behaviors, we can talk about drug injections, or people that had contact with contaminated blood. And of course, people that have already HIV or HBV, because we know that the rate of complications and the rate of mother-to-child transmissions increases in these categories. Of course, we have to consider the possibility that we will have a transmission to blood donations, but if we do the screening tests on blood donors, we will know if someone is positive to HCV. What do we do to diagnose HCV? Of course, we will detect HCV antibodies. This test will detect the possibility of exposure to the virus. So if someone has got HCV antibodies, doesn't mean, of course, that he is HCV positive. We have to distinguish between an infection that is past and an infection that is chronic. We do that through the use of HCV RNA. This kind of exam can be done on everyone that has got a positive screening test. Of course, if someone has healed from HCV, this will be negative, and if someone has got a positive test, this will confirm the infection. What we have to know that there is a possibility, of course, that the screening test is negative in people who have problems with the immune system. It's important to know that almost 30% of cases of HCV and HIV co-infection will result in a negative HCV screening test. So we will have to go deeper and look deeper in this kind of patients. What are the options? The treatment of HCV is something that we had recently developed. So there are possibilities that are not available everywhere, of course, and that are not widely used, because we are talking about a treatment that is developed in the last 5 to 10 years. Of course, we have to know about the protocols, but we know that in the real context, not everything will be available. What are the goals? Of course, the goals are the stop of the chronicization process, the stop of the spreading, and we have as treatment options, of course, the direct agent antivirals. These therapies are therapies developed recently and available for people over 12. This treatment, differently from the one we used on hepatitis B, will not be lifelong. This is a treatment that lasts from 12 to 24 weeks, depending, of course, on the liver function test. This treatment should not be used in pregnant women and in children because of the toxicity. What we do to decide if someone has got liver failure? Of course, we do the same thing we did for HBV. We will do an elastography, so an ultrasound if possible. And if there is not this possibility, we will use some scores, clinical scores, involving, of course, the liver function test and the platelet count. Using these 3 tests, we will decide if someone has a score that requires treatment or not. What are the challenges of this therapy? Of course, this therapy is very expensive. In the recent days, we had the introduction of some of these treatments as generic therapies, and the WHO has the target to reach almost 80% people that are infected with HCV with treatment in 2030. Of course, we are not talking about future, so we don't know if this will be possible, but we know that the birth of generic therapies will improve the success rate of these treatments. This is a rapid overview of the treatment that have been created as of today. Of course, everything is not available, everything is not used, and so I will not get in deep in this subject. And this is the protocol that WHO suggests for the treatment. Of course, we talked about serological testing, we talked about the supplementary testing. These are the possibility of treatment we have, and also the monitoring, because it's important to, if someone has got HCV, if someone is in treatment for HCV, to develop a protocol of monitoring. There is no follow-up need for people that don't have signs of liver inflammation. People with fibrosis should be monitored every 6 months, if possible, of course. People with cirrhosis should be monitored, and also it should be examined if they have gastric varices. That is, this is a problem that can occur with liver failure, of course, and this is a very important point, because the possibility of a rupture could be, of course, could be fatal for someone. It's important to know that is it possible to get reinfected with HCV, because if antibodies persist, there is a chance, of course, of protection, but we know that HCV antibodies are not 100% effective. Talking about prevention, we know that we have to do, of course, a screening process on people that could be at risk and on blood donors. There is no vaccine. It is important to know that, because, of course, as I said, this virus changes very rapidly. It is difficult to develop something that will block it forever and that will last for a long time. So we don't have vaccines, and we don't have passive immunity. So there is no antibodies that can be administered to someone who gets a risky contact. Another infection in the past doesn't give immunity, of course, and there are a lot of vaccines still in development. What we have to know is, of course, that the HCV virus is a virus that has many things yet to be overcome, many challenges that have to be overcome in the line of treatment, in the line of vaccination, and it is important to know that these are a lot of perspective for the future to be developed. I will talk briefly about hepatitis D and E, of course, to get the whole hepatitis group. The hepatitis D, we know that is a virus that spreads only in people that are infected with HBV. So it can be acquired in the same time, and it can be acquired in someone who already has HBV. These are called, of course, co-infection and superinfection. The diagnosis could be done to detect anti-HBV antibodies. We cannot search for the HBV antigen because it is only located in the liver cells. The therapy, of course, includes HBV therapy, because with HBV therapy, if HBV is suppressed, HDV cannot survive, of course, without its host. And also about prevention. Prevention for HBV gives prevention for HDV. About HEV, this is a virus that is similar to HAV, of course, because doesn't have a sexual transmission, is got a fecal oral transmission, has a pretty short incubation period, and a presentation that includes hepatitis symptoms such we talked before, fatigue, malaise, and a resolution that is in 90% people spontaneous. It's important to know that in immunocompromised patients, it can lead to chronic disease. And in pregnant women, has a 2% rate of mortality, opposed, of course, in less than 1% in adults. And the possibility to develop liver failure in 50% of cases. How to diagnose the virus? We will do serological testing for IgM and IgG antibodies, and we will know if someone has got an active infection or someone has passed through an HBV infection. The only prevention we know about this virus that is not so widely spread is, of course, sanitation. This is pretty much what we have talked about for HAV. Now I will leave you two case scenarios. Of course, these were about HBV. So when we decided to split the lecture, the meeting, in two parts, these are not very relatable, but I will leave them to you to use. The first one talks about a male who has malaise and no history of hospitalization, and someone who drinks a lot of alcohol, doesn't smoke, doesn't have drug abuse. What do we search for? We do liver function test and we find high AST, a positivity for HBV antigen, and then what are we talking about? What test would we do next? This is, of course, related to the HBV protocol we saw last time. What do we do? What do we do? I leave to you the answer. I know that you are better at this than I am, so please.
We are going. Hello.
Hello,
Daniela. We need to go to the serology. We have to do the antibodies and the pattern for HBV.
Okay.
that's correct.
We search for DNA. Okay, we do an HAV test, that is always useful, and of course we search for the antibodies. We do also an exam that shows a low level of platelets. That can be one of the signs of liver failure. So what do we do next? Sorry, I give you the answer before. Of course,
For Daniela is absolutely pleonastic, I think.
Oh, it's okay.
Okay. Then, so there is this ultrasound. We see that someone has got some liver disease, some signs of big spleen. So that means that there is signs of liver failure. And then, we decide what is the stage of this liver disease. Of course, after we will use some index I talked about, such as HAPBI. I'm not very familiar with.
Sorry, a question for you all, for Daniela and for the others. When you have a patient with a suspected or an hepatitis B infection, or I mean, even for hepatitis D infection, what habits to follow the patient with the ultrasonography or with the clinic? or and the clinical tests, I mean, as APRI and FIB4, or by laboratory tests?
Hello? The best would be laboratory tests, monitoring the liver enzymes. Clinically, the ultrasound picture may not change so much depending on the stage of the liver disease. But the liver function tests would be paramount for monitoring.
So you use every kind of test to I mean, every you use a comprehensive evaluation of the liver function, every kind of exam, or specifically you follow some specific test or specific I mean, instrument such as ultrasonography instead of the others, or what else?
Specifically, I think liver enzymes, AST, and then comparing it with platelets, finding out the APRI score. But ultrasound scan is also good, yes, to look at for fibrosis in this case.
Let's see what they do. Okay, they ask if treatment is recommended and what monitor does he require. So for the stage of liver disease, they calculated the APRI, that is a status of cirrhosis, and they ask if someone who has liver cirrhosis, treatment is recommended. Of course, the answer is yes. They follow the treatment regimen with tenofovir, as we said before, and as everyone agrees. And then we know that is a lifelong treatment, and what we do after. Of course, there is another thing we have to consider, that this patient was an alcoholic, so it is important, of course, to get also a social counseling if possible, to help him to get through his alcohol problem, of course. And as we said before, we talked about this in the last minutes. Of course, we said that it requires monitoring with, we said, of course, ultrasounds, and you told me that you usually do liver function tests. And then let's see, of course, we were right. And also he has to be screened every 6 months for the evidence of hepatocellular carcinoma.